Okay. So welcome to the McLean Hospital Crafting Support Project 2025 Family Webinar Series. I'm Dr. Julie McCarthy, and I'm a clinical psychologist at McLean Hospital. And tonight I'm very excited to have you with us for a presentation on building family resilience with bipolar disorder and more with our very own Dr. Emily Carroll from McLean Hospital and Harvard Medical School. And before we begin, I'll go over just a few reminders. So folks are welcome to change their names for privacy purposes or make questions or comments in the chat anonymously. Please enter any questions that you have in the Q&A box, and we'll be answering questions at the end of the presentation. And we ask that you use the polls and chat for any audience participation and to share any comments or resources that could be of interest to the group. And we'll be recording the presentation in Q&A. And when recordings are available, we'll let attendees know. The first one from this year is already online. And to continue to improve the webinar series, we encourage you to complete a brief, anonymous, and completely voluntary feedback survey to share your thoughts, preferences, and any ideas for future webinars, because we really want to make this as useful as possible for you. And this information helps us for quality improvement purposes and may be shared anonymously in the future with researchers or people interested in further expanding these types of supports for families in the future. So I'll put this link in the chat for anyone who might need to go early. Okay, great. And so before we get started, we'll have our agenda, a little bit of intro for why we're all here, go into our presentation, then we'll do the Q&A and closing remarks. So first, I'm going to launch a poll to get a sense of who is with us tonight. And what I'd like you to share in just a moment is what best describes your role? Would you say it's family member, person with lived experience with mental health challenges, clinician, or none of the above? And you can also rate if you have intersecting identities as well. All right. So we'll be closing the poll in about 3, 2, 1. Okay. So the majority of our attendees tonight are family members, 85%. We have 10% who are individuals with personal lived experience with mental health challenges, and 20% are clinicians. So thanks so much for being here with us tonight. Okay, so why do we have the Crafting Support Project Family Services? If you're new here, welcome. We are here because so many of us may have been in the position ourselves or worked with folks who have tried to help a loved one who may have needed some services or some assessment to see if they need services to really support their mental health recovery. And sometimes it's not always clear where to start, or maybe you're in the thick of it and it's very overwhelming to navigate all of those different resources and services. And so we wanted to create a venue to share evidence-based treatments and resources that could really be helpful for families and their loved ones trying to get the best mental health support possible. So this year, we've been very fortunate through our philanthropy funding to have this initiative to offer webinar series Thursdays, 5 to 6 p.m. And this is our third webinar this year, and we have a great lineup to come. And for our past webinars that I had mentioned that are online, feel free to check out our YouTube channel with the QR code on the screen. We also offer one-on-one coaching for McLean families. Right now, this is focused on families who have loved ones who have experienced psychosis, and we're also likely continuing to expand that in the future as well. And so this is up to 8 weekly one-on-one sessions with a coach on Zoom with someone like me or someone trained by me. And this is offered through this year, and we're also preparing to offer insurance-based services in the future. Right now, this is free, thanks to our generous donors. So if you're interested in getting in touch about this and would like to learn more, feel free to email me at jmccarthy@mclean.harvard.edu. Okay, so in a moment, we will be turning things over to Dr. Carroll for her presentation. And a little bit about her. Dr. Emily Carroll is the clinic director of the McLean Hospital Support, Treatment, and Resilience, or STAR program. And she's involved in clinical outreach, research, and training initiatives. Her expertise is in early identification and intervention for emerging serious mental illness in teens and young adults, including psychosis spectrum and bipolar disorders. She's also a member of the Laboratory for Early Psychosis, or LEAP Center. that Dr. Carroll's clinical and research interests include the etiology, trajectory, and treatment of psychosis spectrum disorders, and she's particularly interested in the relationships between stress, family environment, and symptom recovery. So very relevant to our audience today. And Dr. Carroll completed a clinical fellowship with McLean's College Mental Health Program and the Division of Psychotic Disorders. And she completed her pre-doctoral internship training here at McLean in the Behavioral Health Partial Hospital Program. And to cue us up for how familiar folks are with some of the topics that she'll be sharing today, I'd like you to share with us in the poll in just a moment how familiar you are with something called family-focused therapy, or FFT. So let me launch that poll now. And you can share whether you're not familiar at all, like never heard of the term, mildly familiar, maybe you've heard of it, but don't know what it is, moderately familiar, like you've looked into it or read about it a little bit, or very familiar. Maybe you've participated in family-focused therapy, or maybe you lead it yourself. All right, and we'll give folks another couple seconds to complete their ratings. And we'll close the poll in 3, 2, 1. Okay, so we have 80% of folks saying that they are not familiar with this approach, so you are definitely in the right place tonight. We have 16% who said they're mildly familiar, and 4% who said moderately familiar. And Dr. Carroll, you are the expert in the room tonight in terms of who's very familiar. Okay, so I'm going to stop sharing my screen so you can take it away. Thanks so much.
Thank you so much, Dr. McCarthy. I am so thrilled to be with you all. Just give me one moment as I share my screen, my slides. Okay. Here we go. Alrighty, well, that poll was so very helpful, and I'm really glad to be introducing you all to this topic of family-focused therapy. We'll be thinking about this in the context of bipolar disorder and also psychosis spectrum illnesses as well. And I hope you walk away with some increased understanding of family-focused therapy, FFT, but also some tips and some starting skills as well to give you a taste of what can be covered in this type of work. So when we're thinking about the family environment, I want you to consider your own family environment, families that you know of, families that you've worked with, and take a look at these different statements and just think about how, have you ever had this thought? Has a family member ever shared this thought with you? You don't get me. You don't understand. I don't know what they're thinking. I don't know what's going on with them. They won't listen to me. I don't want them to struggle again. I'm afraid they'll have another episode. We don't know what will cause another episode. It feels like anything can be a trigger. These are very, very common statements that I hear all the time in my work with either individuals who've experienced mood episodes or psychosis symptoms, or family members who have a loved one who's experienced those symptoms. These are very common, and they're especially common when there has been a recent episode. These thoughts and these feelings are coming from a place of love and concern and wanting to help the other person, but they can also lead to feelings of stress, uncertainty, and fear. Because bipolar disorder is often episodic, so what that means is it can be individual episodes that can happen at different times. Similar psychosis symptoms can also be episodic. That can create a lot of uncertainty and fear during periods of stability of what could happen next. So if we think about the opposite of those statements that I just shared understanding between family members around the individual's mood episodes and experiences, their hopes and goals, their fears and concerns, and also the family members as well. Effective communication between the individuals in a family, problem-solving ability, can all increase hope and can lead to more supportive family environments and better outcomes as well. And these are the things that family-focused therapy, FFT, is explicitly focused on. And I should have said, I'm going to be using the term family here, and I mean using that term very generally. So from an FFT perspective, we think about family members as the individual's support system. It could be first-degree relatives, any other individuals who are part of that family unit. It could be, partners or other loved ones as well. So we use that term quite flexibly. So FFT was originally designed by Dr. David Michelitz. The explicit goal of family therapy is to reduce family stress, conflict, and affective arousal, that is the emotional environment of the family, by enhancing communication and problem solving among the family members. So it sounds straightforward, but family stuff, family conflict, communication, problem solving skills, these are things that have a lot of history and are really important things to be targeting in this work. FFT was originally designed for bipolar disorder and for schizophrenia, and it has since been really adapted to individuals with a number of different experiences. It's been shown to be helpful for youth who might have increased risk factors for these different symptoms. And it's also been generalized to other young adult populations that aren't as symptom focused as well. So it can be helpful across the board. So taking a step back, thinking about why family therapy in general, especially among individuals who might have had mood episodes related to a bipolar disorder or psychosis spectrum illness. Number one, family members can be a big source of support. If that individual is living at home, they might be seeing them the most. Family members might know that person the most as well. For our younger individuals who've experienced mood episodes, family environment can be even more supportive and helpful. The family environment can also influence symptoms and mood episodes. It can make them more challenging. So there's a lot of the FFT work has shown that if you target negative stress and feelings in the family, so conflict and overall stress, that leads to fewer mood episodes. So if you're targeting the family environment, it can decrease the likelihood of mood episodes in the future. Stress in general can be a negative influence on symptoms. So if the family environment is very stressful, that can be a negative aspect of that. But the family environment can also offer a lot of protective factors as well. So more supportive environments, de-stressing, encouraging can lead to fewer negative outcomes and increased engagement in that person's life. Symptoms and mood episodes can also influence the family environment. So we were talking in the beginning, it can lead to a lot of uncertainty, a lot of concern from the other person. This concern often comes from a place of love, but it can really foster that level of stress and concern as well. As I mentioned, bipolar disorder is often episodic. So there's periods of time where the symptoms are more acute and periods of time where the symptoms are more stable. And so during those stability times can be a really nice time to lean in and develop more of these skills. There's a lot of work showing that mental health symptoms can also occur across family members. So one thing that family focused therapy really focuses on, lots of focuses, is that it's really targeting the family as a whole, almost as the individual client, rather than putting all of the attention on the individual who may have had symptoms or mood episodes in the past or currently. And so that way, all family members can benefit and learn from each other from the process. There's also been a lot of research focused on understanding family-focused therapy and adapting it to really utilize the best parts of it to make it as accessible and less time intensive as well. Okay, so a little bit about that research. So there's been a lot of clinical trials evaluating the effectiveness of FFT. I was actually lucky enough to be on a clinical trial when I was in graduate school. It was one of my earliest clinical experiences, and it really led to laying a strong foundation for me in the importance of family therapy, and also the important role family members can play in an individual's recovery. So family therapy, family-focused therapy plus medication was shown to delay relapse of mood episodes and improve functional outcomes more than crisis management plus medication or a brief family psychoeducation. So indicating that there was something additive and important about the family-focused therapy. And these benefits were shown to be stable across 1 and 2 years. It was also shown that families that have higher stress and more negative communication styles also showed greater treatment responses as well. So that's showing that even with high levels of distress and challenges, a lot of gains and positive impacts can be taken away from this treatment. And as I mentioned, there's been a lot of work trying to adapt this to make it as accessible as possible. So these trials have shown that both the intended long treatment, so the 9 months of treatment, and briefer interventions, as short as 4 months, have all shown to be effective, which is very encouraging because we want to get these skills as quickly as possible. And often people have a lot going on in their lives. All right. So thinking about the specific goals of FFT, so the number of goals are, number 1, to reduce tensions in family relationships, improve families' communication. So this is the way that family members talk to each other. Increase family members' understanding and acceptance of the symptoms that the individual has experienced or is experiencing, or if illness feels like a good fit in terms of a label for that person. The next goal is to assist in the family develop problem-solving strategies, which we'll go into in a little bit more detail. And a key part is incorporating the family's specific goals as well. So we want to make sure that this is really specific to the families who are engaging in this work. Okay. So the goal is to help families leave with knowledge and understanding about the individuals who have experienced mood episodes or symptoms, about their specific symptoms, and their risk and protective factors. We want them to walk away with a fully formed relapse prevention plan, which I'll go into in more detail. In short, this is I like to call it a wellness plan that everyone is on the same page for, on how the individual wants to be supported during times of increased symptoms or times of increased stress. And explicitly laid out so people know what their role is and what is helpful for them to be doing and what could be not as helpful. We want them to be walking away with 5 specific communication skills and a strategy to solve problems. And the goal here is that this will all increase the family members' resiliency to future stressors, future challenges, because life in itself is incredibly challenging and stressful. And so we want families to feel empowered to be able to still engage in their plans, equipped with these additional skills and support from each other. So FFT is a manualized treatment. So what that means is there's a manual out there that is a standard way that all therapists and providers who are engaging in this work can follow. The kind of full treatment is 12 sessions, which can be, implemented in whatever way feels like it's the best fit for the family's schedule. It includes, at its minimum, 4 sessions of psychoeducation and relapse prevention planning. So psychoeducation means the family members learning about how different mood symptoms are defined, how the individual in the family might experience those symptoms, so everyone can be on the same page in terms of decreasing that uncertainty and fear and having a shared supportive language to talk about these experiences. 4 sessions of communication enhancement training. So these are learning about different communication skills and practicing them live together as a family with the therapist as a coach there. And then 4 sessions of learning how to use a problem-solving model and taking active problems that the family is navigating and utilizing the model together with the support of the therapist there. And then, of course, additional sessions can be scheduled as well. I will say from my experience of doing this for a long time now, when, my first experience was in a study where I had to be very manualized and follow the explicit manual and steps, what each session should include. My next experience was I worked in a bipolar specialty clinic where we were providing this intervention for family members, and we did not have to be held to the standard manual. And it was very tempting, and at times we did adapt the order to these different sessions. Usually the biggest temptation to adapt the order was maybe a family comes in crisis, they have a lot of problems that they want to be solving in that moment. And so we would skip the psychoeducation and relapse prevention planning and jump right into problem solving and trying to use the communication skills at the same time. And every time we felt tempted to do that, we went back and had wished that we had done the psychoeducation or ended up backtracking to do the psychoeducation, because it really lays a very strong foundation and groundwork for the family members to get on the same page, to increase that willingness to listen to each other and even use the communication skills and be willing to problem solve. So you take my learning and that there's a reason for this order, and that psychoeducation can be a really powerful intervention step. Okay, so what do I mean by psychoeducation? So these are the different topics that are covered over those 4+ sessions. So we talk about why FFT, so a little of what we've already talked about, and getting people's buy-in. We talk about, what we're going to be focused on, so everyone agrees and feels like it's a good fit. We establish a family meeting, and this is something that I'll go into a little bit more detail on, as it's something that if you are in a family right now, you could start to implement as well. We talks about the signs and symptoms of the illness that the individual has experienced, or the symptoms they've experienced. Again, because mood episodes can present in so many different ways. Psychosis symptoms can present in so many different ways. And it's important to use individualized language when we're talking about that, so it feels specific to the individual and the family, rather than just reading, general stereotypes or things out of a textbook. We talk about the vulnerability stress model, which is a model to understand how do you increase protective factors and decrease risk factors. We talk about stress and coping, how to keep the family environment lower stress, and then ending with the relapse prevention plan. So I'll go into this in a little bit more detail. So the family meeting. So in the very first session together, we establish a time and every family member agreeing on a family meeting. So what is meant by a family meeting is that outside of the FFT sessions, the family members have agreed upon time when they're always going to be getting together weekly. And if they live together, this is in person. If they don't live together, then it's over phone, over Zoom. And the purpose of that in the beginning is just to have a relied upon time when everyone's going to see each other. As many of you probably know, our lives are very busy, and sometimes we're only seeing each other to talk about the hard stuff. And so that can lead to some avoidance or unwillingness to talk to family members or to meet up, because it feels like every time you do, it's the only time you have to talk about the most things that are the most priority. So with the family meeting, you're establishing a time where you're always getting together. Maybe you talk about things you need to problem solve, or maybe you just have dinner together, or do other things. And that it's ideally a mixed agenda for that piece of it. So we established the family meeting right away, and this is something that you could start doing now if you wanted to. The other piece of psychoeducation that I wanted to share with you is the vulnerability stress model. So this might be something that you have heard about before. It's not specific to FFT. It's kind of a general approach and principle for often for skills-based work. You might have heard about it as the diathesis stress model as well. So this is the idea that we are all born with our own specific genes, which can be risk factors or vulnerabilities, and that life is very stressful. So it's impossible to avoid stress in those ways. And those things together is our diathesis, if we're thinking about the diathesis stress model, or our vulnerabilities going into life. And then there are specific risk factors or protective factors that might increase our vulnerabilities or decrease our vulnerabilities. So I'll talk about that with a quick example just to illustrate that I like to use with families. So I don't know if you can see on the screen, but I have red hair and very fair skin. So my genetic vulnerability is I'm very predisposed to sunburns and skin cancer runs in my family. So that would be my vulnerability, my genes that I'm carrying in here. Stress in this case would be the sun. So I can't change my genes in that way. And I don't want to avoid the sun. I like going outside, I like hiking, and it would be impossible to avoid all of the sun. So if I ignore all of those risk factors and I don't do any kind of protective factors, I could have some challenging outcomes in always getting sunburn, increasing my risk for skin cancer. Protective factors would be putting on sunscreen, maybe avoiding, high exposure times, practicing some acceptance and always having to wear a hat and long sleeves. And if I do that, I might be less likely to get a sunburn or to get skin cancer compared to someone who doesn't have as much genetic vulnerability. So in that way, I'm increasing my protective factors. We can think about that as in the same way for mood episodes. Someone might be more genetically vulnerable to mood episodes. And we know stress can increase someone's risk factors for a mood episode. And if they're increasing their protective factors, which might be engaging in treatment, keeping a healthy sleep schedule, keeping up with exercise, then that person might be decreasing their risk factors for a mood episode in the future. And so what we like to do in this beginning period is go over the general risk and protective factors related to mood episodes and psychosis symptoms, and then also make it really specific to the individual and the family environment as well, in terms of what are their goals. So if they're wanting to go to college or in college, what might be particularly stressful times like finals that could lead to a change in sleep schedule? How can that person proactively think about increasing their protective factors during that increased risk time to help increase their likelihood of having a better outcome and getting through finals, for that example. So we make it really specific to the individual. So eye on the time. So relapse prevention planning, I'll go over a little bit quickly. So this is done in a lot of different treatments, especially if someone is navigating mood episodes. But what is specific to FFT is making it really about the family. So the idea here is to decrease uncertainty and fear. We talked about how that in the beginning, that can be a big thing that's related to worry after a mood episode, and helping each family member be on the same page of, one, what are you looking out for in terms of risk factors or early warning signs that a mood episode might be starting to appear, and have everyone be on the same page of what the individual wants other people to do and what they want to be doing during that time to, again, increase the protective factors to decrease the likelihood of the mood symptoms worsening over time. So this is an example of what we think about in a relapse prevention plan. It's important to break it down into different periods. So green flag here means no increased risk factors or added stressors. And this is important because what we really help family members not do is overinterpret general changes in mood, stress that young adults, individuals experience over time generally, and have everyone understand what might be a mood that suggests, oh, this might be something that could be turning into something that could be more impairing, so a yellow flag, and what might be more acute, so something that's suggesting a mood episode is more prominent right now. And breaking that down into what is observable from a behavioral standpoint and what types of thinking styles and emotions that individual might be having. And helpful to break it down, what can the individual recognize and what might be easier for other people to recognize and harder for the individual. And then this part is the key, working together to talk about what does the individual want to be doing and what do they want other people to be doing during these different stages to get support. And usually we have people write this down, hopefully in their own handwriting, or that they write it in their own words so it feels really relevant to them and not something that's just been handed to them and they agree upon it. And then for communication enhancement training, these are the different areas that we focus on. We start with expressing positive feelings. Then we talk about active listening, making positive requests for change, communication clarity, and expressing negative feelings. These are all sound simple and they're incredibly hard to do because what often comes up with family members is we feel like we know the person so well. We do this thing that is in CBT language called mind reading. So we talk as if we know exactly what the other person is thinking or feeling without making sure we're all on the same page. So expressing positive feelings and active listening is where we start to help everyone feel like they're on the same page. So an example of what one of the skills looks like, and this is something that you could write down and take with you and practice with people in your life, is you want to always look at the person. That's in any of the communication skills. And then for expressing positive feelings, you want to say exactly what they did that pleased you and tell them how it felt when you did that. So example, I might say something to my husband of, when you packed our daughter's lunch last night, it really helped me. So I said exactly what he did. And then it helped me feel less overwhelmed and a little bit calmer. So using a feeling word to describe how you felt. And we have people start there and even give them some activities to help them do it more often. As a place to, again, bring family members together, create that sense of connection and help people feel seen and recognized for the things that they're doing to support each other. So this is something that I encourage you to test out and try with your loved ones and the people in your life. So then problem solving, here is a sneak peek at the framework. So we spend a lot of time going over this framework and taking problems that the family is navigating and applying it to this framework. And if you walk away with any one part of this framework, I hope and encourage it to be this agree upon the problem starting with. Usually when we have a problem that we're trying to focus on, especially with family members or others, we skip into the brainstorming and coming up with solutions without really confirming, are we all on the same page about what the problem is? And if we aren't on the same page, we're never going to get to a place of coming up with a solution that everyone feels comfortable with. We've skipped a very important piece. So we spend a lot of time agreeing on the problem. And often when we identify a problem, we break it down into like 5 or 6 different problems that could all have different solutions to it. So this in general really slows the process down and gets the family on board with taking one problem at a time and agreeing upon the steps. So think about that next time you're trying to solve a problem. Is everyone on the same page about what the problem is? Then this brainstorm stage is really important, brainstorming all of the possible options without expressing judgment and writing something off. Then we go into the discussing the pros and cons and carrying out one solution, and we view it as a test. So we're going to test it out and then come back together. And so we spend a lot of time thinking through that and practicing it together and then having the follow through together as a group. This is just the worksheet that we use. Okay, so we covered a lot of different topics. I'm excited to answer your questions and hope this gives you a taste of what family-focused treatment could be like and why it could be helpful. If you're wanting to learn more, this bipolar disorder family-focused treatment approach, it's a clinician model, but I think it does have a lot of good, useful resources for non-clinicians as well. And then I use this guide all the time with individuals and family members who have lived experiences of bipolar disorder. I think it's a really useful and applied guide and workbook, so I recommend that. And then there's also a clinical trial actively going on right now, recruiting for individuals who might have increased risk factors for psychosis and are a teen or young adult. So if you're wanting to engage in FFT through research, there's a local trial happening right now at the BI, so that is real. All right, so hopefully I've helped you understand how a shared understanding across family members, increasing communication, empowering people with a problem-solving framework can increase hope and decrease vulnerabilities related to future mood episodes and challenging symptoms. I'm excited to answer your questions.
Great. Thank you so much for this wonderful overview of FFT. I feel like this is so nice to hear that. I also have the Bipolar Disorder Survival Guide on my bookshelf right now. So anyway, yeah, let's turn things over and we'll kick it off with our Q&A. So feel free to put any questions you have in the chat or the Q&A box. One person who popped in a question earlier in the presentation was asking about what it means, this term psychosis spectrum disorders. Would you mind starting just to share a bit of that clarifying question? I had put that in the Q&A as a response, but just in case anyone missed it.
Yes, absolutely. Great question. Psychosis spectrum illnesses or disorders refers to a range of different diagnoses. The important piece there is psychosis is viewed as a symptom. It's not a diagnosis in itself. And so when we say psychosis spectrum illnesses, it's different mental health conditions that could include psychosis as a symptom. So bipolar disorder with psychosis could be one of those. Schizophrenia falls under that category. Depression with psychosis are some examples. So it's illnesses where psychosis is playing a role in some way.
Great, thank you so much. So another question that came up is how can people access therapists who can do FFT with them, either knowing who's been trained in that or if they are, how to access them?
It's a great question. I would say most often if you're working with someone who's in a bipolar disorder specialty clinic or a first episode psychosis clinic, often those are where the most trained clinicians are. Sometimes programs advertise on their website that family-focused therapy explicitly is part of the treatment that they provide. Sometimes you have to do your own little asking. So now that you all know that term, I encourage you, if you or a loved one are interacting with clinicians, that could be a question that you ask. Do you know family-focused therapy? Is that something that you offer now that you're empowered to know about it?
Great, that makes sense. Just kind of like someone might ask, oh, are you trained in cognitive behavioral therapy or CBT? Okay, thank you.
Yeah.
All right, and so this is a clarifying question. Is FFT only for, the in-person kind of therapy with the family, or can it be done on telehealth or both?
It can be done on telehealth or in person. Yep. One of the things, either if it's in person or over telehealth, is having as many family members there as possible. Because we're looking to, like I said, increase understanding and skills across the family to target the family environment. So if there are key players who contribute to the family environment who aren't there, that can hold the effectiveness back a little bit. And we know that can be very hard to get everyone in the same virtual room or physical room. And so as many people as possible is always better than no one at all.
Sounds good. So it sounds like, people wouldn't be prevented from engaging in FFT if only part of the family could be there, and also effects could be further strengthened with everyone there. Okay. So the next question is about, does the training include how to talk to someone with anosognosia or lack of insight about even recognizing that there is a problem, to your problem solving slide, maybe not even recognizing the need to have conversations together?
Mhm. Yep, that is a really excellent question. And that's why it's so important not to skip the psychoeducation piece of it.
Yeah.
Because every family member is getting on the same page of what their challenges and symptoms might be, and not making about maybe the individual person who might be having some of those symptoms that are creating some barriers for them engaging in treatment. Could be focused on other family members and what
Mm,
they're needing and wanting and support there.
mm,
And so by doing that, it makes it about what is the family needing right now versus the
right.
one individual too. And in that process, you learn about each family member's goals, and what they're wanting to accomplish more in their life or do more effectively in their life. And usually that can be a helpful source of engagement, and door to go through if family members are observing other challenging symptoms getting in the way.
Gotcha. Thank you. And I guess this is kind of a related question. What advice would you have for family members? Let's say there are two parents who might have a situation where one of the parents is interested in this type of approach and mental health services for their loved one, and the other parent may not recognize the need, as the family member. Any thoughts or advice there?
Yeah, that comes up a fair amount, I would say. And I think it can depend on what the stress level is in the family. So
Okay.
people might not agree on what the stressor is, but usually people can be on the same page that things are feeling challenging and things are feeling stressful. And so
Mm,
one of the goals of FFT is to decrease overall stress,
mhm.
and increase communication and time together. And usually that is a helpful piece to get everyone on the same page. They might not
Right.
all agree around why they're not talking and why there might be stress, but wanting to decrease that overall. So that can be a helpful buy-in for folks.
I like that. Trying to find the common ground. We may have different
Hmm.
opinions on why things are stressful, but we can all acknowledge that the stress might be there.
Yep.
Okay, so another question we have is, um, you know, is this something that the patient or person at the center of experience has to be a part of with FFT with the family, or could it be done separately?
Ideally, the person is involved because,
Okay.
again, with the psychoeducation piece, it's the individual's opportunity to share what their symptoms feel like for
Mm,
them
mhm,
and clarify concerns that the family members might have. So something that comes up commonly that makes the individual not want to engage is family members misattributing certain experiences, general fluctuations in personality or moods as this person's having a mood episode. So then
oh,
that leads to the individual not wanting to share information,
I
which leads to
see.
the family members kind of hyper attention to other symptoms because out of love and fear, they're not wanting to miss something. So it
Right.
gives a really good opportunity to help inform each other around what are our concerns and how can the family members better understand mood episodes so that they are more attuned to what is actually might be a concern and can
Mhm.
feel less concerned about things that are just natural changes and fluctuations that we all experience.
Gotcha. So having ideally both parties there from the get-go can really help some of the concern about maybe doing it together in the first place.
Exactly. And we always take the person's lead in terms of how much information they're wanting to share.
Sure.
And a big piece of it is having every family member share their mental health experiences and
Oh,
symptoms as well. Again, to
okay.
make it so it's not focused on one individual.
I
It's really
gotcha.
learning about each other to increase that vulnerability because it can feel unfair if just one person is doing all the sharing in that way
Good
as well.
point. Okay. Yeah. Well, thank you for expanding kind of the scope of, who is discussing what, because
Mhm.
it really does sound very collaborative. And I guess another question is FFT training available to anyone, or how can people register? I guess part of this question might be, is this just available to clinicians, or is it available for family members to learn, or both?
Yeah, that's a good question. I don't know of if it's been translated to family members,
Hmm. Mhm.
but I know that there are, there's the manual, so there's
Mhm.
the book reference that I shared, so
Okay.
family members can read that themselves and practice that piece of it. Same with clinicians. I don't know of any active trainings that are happening right now, but I would say
Mm.
that the book is a really good starting place.
Yeah.
And then that trial that I shared as well, reaching out to the folks who are leading that, it's across the country, so I'm not going to be able to
Mhm.
name all of the places, but I know it's
Right.
in Boston, UCLA, and a number of other states. So it's quite extensive in terms of the people who are engaging in it right now.
Wonderful. And so someone is asking also about kind of finding programs that are accessible for people who are on the younger side. So say if
Mhm.
someone has a child with bipolar disorder diagnosis, who's under 18, maybe around preteen, 10, 11, 12, et cetera. Um, it's hard sometimes to find services to fit every age group. Is FFT offered for people in that preteen age?
Yes, yep.
Okay,
So the
great.
trial that I was on, I think the lowest age it went to was 10.
Oh,
And so yes, the some of the handouts that I clicked through very quickly on the slides were actually the child versions, not the
oh,
adult
okay.
versions. If you caught any cartoons, I tried to not
Got
include too many of those. So
it.
yes, there's a child manual and there's an adult manual. Yeah.
Got it. That makes a lot of sense. Okay. Another question that someone had was, how does FFT differ from other evidence-based therapies like CBT and DBT? You kind of alluded to the fact that certain elements, are parts of lots of treatments or approaches. So I guess
Mhm.
could you share some examples, not holding you to the full exhaustive list of, similarities and differences?
Sure. I think from a general skills perspective, there's a lot of similarities. I think the key difference is the psychoeducation aspect
Mm,
and the family unit rather than the
yeah.
individualized client. So when I said like it's important not to skip those 4 sessions, even as tempting as it can be, there is a powerful aspect when each individual is sharing their experiences, coming up with that shared language to talk about symptoms as well. And I think
Mhm.
with mood episodes, usually it's happening after an episode has happened. So there's something really specific to be able to be talking about in that way. So I would say that's the major difference. The common components, relapse prevention planning happens in a lot of different interventions. Psychoeducation generally can happen across a lot of interventions. Communication training too, craft, the whole host of
Community
this
reinforcement
webinar
therapy.
it's a
Yeah.
big piece. So that part isn't unique. The skills might be a little bit different, but the core idea of how do we talk to each other in a more effective, supportive way kind of cuts
Mhm.
across a lot of different interventions.
Yeah, definitely. Thank you so much. Um, Somebody asked a really important question about bipolar disorder. So bipolar disorder could be a broad term. There are many different types of symptoms that could all qualify for bipolar disorder with certainly shared core symptoms. Could you share a little bit about your definition for people who might be less familiar with the criteria?
Mhm. Yeah. And that's again why the psychoeducation is so
Ah,
important because when we
yes.
just say bipolar disorder, it could mean so many different things. So yes.
Mhm.
So bipolar disorder is considered a mood illness. So it can present with ups and downs. So depression would be an example of the down. So a
Mhm.
continued period of time when someone's experiencing depressive symptoms,
Mhm.
and then periods of elevated moods where they're experiencing more activated symptoms. So maybe sleeping less, doing more activities, thinking very quickly, making decisions maybe they typically wouldn't make.
Mhm.
And the challenge with bipolar disorder is it's episodic and you need certain types of episodes to fit in the different categories. So it is not unusual for someone to have different diagnoses over times if those symptoms change. So for bipolar 1 disorder, that's when the symptoms of activation are causing the most impairment for someone.
Mhm.
From the DSM perspective, you only need one of those episodes to then have bipolar 1 disorder.
Mhm.
For bipolar 2 disorder or bipolar disorder that includes hypomania, you need both the depression and the hypomania symptoms as well. And for depression, you just need the depression. So someone first had depression symptoms present, and then over time maybe had hypomania symptoms present, and then over more time had hypomania symptoms present. Their diagnosis could change over time. And so that
Mm.
can lead to confusion as well for individuals and family members, which is why that psychoeducation piece can be helpful as well.
Yeah, thanks for clarifying. So one question that families have often asked me and the work that I do with them is, I would love to have a wellness plan with my loved one, or they started it with their clinician, or they said that they were going to, but I haven't seen it yet. And so I guess in those scenarios where for whatever reason, maybe folks aren't ready or willing yet to have those meetings together, but family
Mhm.
members would love certain components of FFT, like a wellness plan. Um, what recommendations, if any, do you have about how to maybe talk with a loved one about putting something like that together, even if it's not in the formal context of an FFT therapy kind of session?
Yeah, excellent question. Yeah, that's a very common thing that can come up. I think picking something small so that
Mm.
you're focusing on one thing rather than a whole plan can be a helpful place to start
Yeah.
and increase the likelihood of it being able to be finished. Often people are focused on the most concerning symptoms that might feel a little challenging for the other person to engage in. And so it could be something that they're already doing, and you want to help support them continuing to do that. So maybe they're already going to therapy, and you want to help them stay in therapy, sharing why you're talking about it. So um, I want to help decrease stress related to getting to your therapy appointments. Is there anything I can do to help you make it so that you can stay on top of your therapy appointments? And
Mhm.
putting the power into their hands. And if they say, no, I got it, then the parent can say, or the family member, all right, so you don't want any help from me. We're on the same page. I'm understanding you're not wanting help. And so they're getting their instructions of like their role is to not provide help.
Right.
Um, and then you could add, how might I know that you need help? I think is the
Mm.
second important piece of like, okay, you might
Mhm.
not need help now. Would there ever be a time when you would want more help? And so that
Mm.
might help the family member feel like they're not just handing over all of the responsibility to someone else
Mm.
as well.
Mhm.
So picking one thing and having it both, how can you maintain what you're doing now? And is there ever a time when you might want me to be doing something differently?
Okay. I think that language is so helpful to have, that people can easily ask their loved ones. And one of our attendees brought up a really good point for referencing one of our past webinars, just sharing that something called Wellness Recovery and Action Planning, or REP, could also be helpful. And we have those groups at our hospital as well. So yeah, I guess to end out the Q&A session with a couple more questions, one, I guess, would be, you know, thinking about your work with families, whether it be in grad school or, different clinics or now, what do you feel like has been some of the most rewarding parts, or the parts of this work that's given you the most hope working with families?
I think it's when family members are changing the engagement. So what I mean by that is what we were talking about a little bit before. There can be a lot of like hesitancy or resistance. A lot of my work is with teens and young adults. And so wanting to really increase independence. And when there can be more humor and support,
Mhm.
like incorporated into these conversations,
Mhm.
that's I see that as a really exciting development and change, even in the way family members are talking to each other.
Mhm.
And then like at the beginning of sessions following that, like the intensity and how people are sitting can present differently. And it is, physical evidence that the energy in
Mm.
the room has really shifted from
Yeah,
this, intensity, acuity, and more of relaxed, supportive environment, even in those small, subtle ways. And so
sure.
those are really exciting moments for me of like, okay, like there's an increased understanding and support that is being fostered, and
Mm.
they can kind of take it from there in terms of, leading the support for each other in that way.
That's great. Thank you so much for sharing. And I'm sure if you're recognizing that, the families and their loved ones themselves are probably feeling that too. All
Mhm.
right. Well, thank you so much for taking the time to speak with us for your presentation. And I'm just going to share my screen to go over some closing remarks and resources. So as we had just mentioned, we have a number of different McLean resources, family groups for different types of folks who are looking for support, whether it be for bipolar disorder, other psychosis disorders, or other types of concerns, or in just general support for mental health for one's loved one or themselves. The RAF group that I had mentioned is led by Lisa McLaughlin Charland, who's one of our certified peer specialists in our division. And so if you have questions, like feel free to reach out to these folks. Also, we have a new service, a risk assessment and early intervention consultation set of services for children of families affected by SMI. So children, we're referring to youth ages 7 to 18 whose parents or siblings have been affected by serious mental illness, including bipolar disorders, schizophrenia, spectrum disorders, et cetera. And this can involve annual family-based assessments. So again, kind of bringing everyone together in a three-session consultation and feedback kind of period to kind of see what's going on, keep an eye on things. This could also include annual cognitive assessments and recommendations there so that people can get the support that they need, as well as monthly psychoeducational groups for adolescents and parents separately. Certainly this theme of psychoeducation is certainly a strong one here. So for folks who are interested, this new service is being run by a psychiatrist with our division, Dr. Vilge Turkoser. And so I've put her email up there, and this is an insurance-based program. And in terms of resources that we continue to accumulate webinar to webinar, I'm going to put in the chat a PDF of some resources at McLean regionally and nationally as well, especially for folks who are not in the Massachusetts area. So hopefully that went through the chat. And then also, as I had mentioned earlier on in our presentation, we would love your feedback on what you think went well with this webinar, what could be even better, and what you might like to see in the future, because we really try to tailor our content to the evolving needs of the communities that we aim to serve. So if you don't mind, please feel free to take a quick minute to click on the link in the chat or snap a picture of the QR code with your phone and share your thoughts with us if you like. And as you're pulling that up, I'd just like to thank everyone who's made this webinar possible. All the people in our division, NIDA funding, and also our generous donors without whom these programs and the coaching that I do with families certainly would not be possible. And our next webinar will be coming up same time next month, second Thursday on July 10th from 5 to 6 p.m. Eastern time. And this will be a different type of topic for us. We'll be talking about navigating housing for mental health recovery with some wonderful folks, Dana Mash and Jessica LaRochelle from the Massachusetts Association for Mental Health. So feel free to join us for that. If you have any questions, definitely feel free to contact me. My email and phone number are here. And thank you again so much. And thank you, Dr. Carroll, for joining us. It was really a pleasure to learn more about your work.
Thank you for
Right.
having me.
Well, I hope everyone has a great night and see you next time.